Let's get started. My name is Andrew Sperling. I'm the Director of Legislative Advocacy for the National Alliance on Mental Illness, and we're really pleased that so many of you could join us for we believe is a step backwards in terms of access for the Medicare Part D program for a range of patients that rely on Medicare Part D for their treatment. So we're going to talk about something called the 6 Protected Classes policy. This has been part of the landscape in the Medicare Part D program since it began in 2006. It was actually put in place originally as sub-regulatory guidance to the Part D plans and the Medicare Advantage plans, and it requires them to meet a basic standard for access across 6 therapeutic categories. This includes, and we'll talk some more about in specifics about some of these therapeutic classes, but it's antipsychotics, anticonvulsants, antidepressants, immunosuppressants, antiretrovirals, and antineoplastics. And the requirement was originally sub-regulatory guidance, and the CMS instructed the Part D plans that they needed to include on their formularies, their preferred drug list. The magic words here are all or substantially all of the medications in these 6 therapeutic classes. And they're all very, very different, but what they do have in common is that the medications within these classes are not clinically interchangeable. And when the Part D program went into effect, they wanted to make sure that particularly low-income and dual eligible beneficiaries that are eligible for both Medicare and Medicaid got access to the medications that their doctor prescribed for them. This has really been the backbone as a matter of policy of making sure that the Part D program provides broad access to the full range of treatments for these beneficiaries that live with these disorders. So we're going to dig into some detail on the background of the policy. I'm going to do that very, very quickly. Then my colleagues Pam Traxel with the American Cancer Society Cancer Action Network, and Catherine FINLEY with the Partnership to Protect Part D Access are going to get into some of the details of what's in the regulation and why we as patient advocacy organizations are so concerned about this. So I mentioned the original sub-regulatory guidance in 2005, and one of the purposes, there were others, was to align the Part D formularies with the Medicaid formularies. These dual eligible beneficiaries in particular were the first large cohort of people that went into the program back in 2006. And they wanted to align those formularies. I want to take a step back, though, and just note the difference between sub-regulatory guidance and a regulation, which is what we're dealing with now as a proposed rule. Sub-regulatory guidance is technically not binding on a third party. Agencies from the Interior Department to the Labor Department put out sub-regulatory guidance all the time, but it doesn't run through the processes of the Administrative Procedures Act, which means it doesn't have the legal effect of a regulation. And we actually, over the years, have sort of dodged a bullet that none of the Part D plan sponsors ever marched into federal court to say, this is sub-regulatory guidance and it's not binding on us, and we want a declaratory judgment that we don't have to follow this. That's luckily never happened. Now, Congress made 2 attempts to codify the 6 Protected Classes policy. First in 2008, under a law called MIPA, that dealt with the Medicare Part B program and the physician payment schedule. We got it codified there. The Bush administration, in the final days of that administration in January 2009, attempted to put out a rule that had a lot of problems with it, and the Obama administration promptly abandoned it. We got it codified again in 2010 as part of the Affordable Care Act. And in January, and that codification kept the sub-regulatory guidance in place legally until such time that the Secretary published a rule, which is precisely what the Obama administration did in 2014, and published a rule that would have removed the protections for 3 of the protected categories that you see there on the screen. That gave birth to the partnership that Catherine's going to tell you about in a little while. They ran the comment period early in 2014, and in March of 2014, the Obama administration abandoned the policy after strong bipartisan opposition from Democrats and Republicans. And now here we are, the next slide, we're now with a new rulemaking undertaken by the Trump administration. This was published just a few weeks ago on November 30th. The comment period runs through January 25th, and we're going to get some more details, both Pam and Catherine, about the comments we're going to be making, the concerns we have with the specifics of what is in the Trump administration's proposed rule. This will become, the plan under the rule is for this to become effective for the 2020 plan year, and the process for what's called a call letter. And this is essentially a solicitation by CMS, usually is done sometime in the spring or late spring for the coming plan year that begins in January, of what the specifications are that all the MA, Medicare Advantage, and Part D plans have to meet. That's sort of lays out the ground rules and the standards that all the plans have to apply for in the coming year. I would note that this is part of President Trump's blueprint on drug pricing. This is a far-reaching set of policies and proposals, some of which are already undertaken through administrative action, some of which are going to require action by Congress. But the issue is no longer being framed as protecting access, that this six protected classes policy is based on protecting access for vulnerable Medicare beneficiaries. This is now being framed as a drug pricing debate. This has somewhat put us on the defensive, and I think Catherine, perhaps Pam, are going to talk a little bit about that. We're going to dig into a second, but I just want to note the sort of high level of what is actually in this rule. It gives Part D drug plans and MA plans greater flexibility to do three different things. Number one is impose prior authorization step therapy for what are called both new starts and clinically stable plan enrollees. We'll get into some more details on why that's a really bad idea. Number two, it will allow a Part D plan to exclude a protected class drug if the product is a new formulation of existing single source drug or biologic. There are a lot of concerns about this on products such as long-acting injectable antipsychotics. We'll talk a little bit more about that in a minute. And then number three, it would permit Part D plans to exclude from their formulary a protected class drug if the price growth of that price increase of that particular product exceeds the basic CPI inflation number, which is usually much, much lower than medical inflation in the US economy. So some big concerns about that third prong as well. So let's dig into the details. And Katie, if I'm right, Pam was going to go next, or Catherine?
Pam is up.
So let me introduce Pam Traxel. She's the Senior Vice President of Alliance Development and Philanthropy at ACS CAN, and she's a colleague I've worked with on many, many different things. I would note, we have stayed, as part of the partnership, we have really tried to have patient groups that are affected by every one of these therapeutic classes involved, and we've been very, very grateful for the leadership and the very strong engagement of ACS CAN on this issue. Pam, the floor is yours.
Thank you, Andrew. I really appreciate it, and I echo those comments. I think it's incredibly important that all patient advocates engage in pushing back against this rule. As Andrew briefly outlined, it's potentially pretty devastating to Medicare beneficiaries. And I think that one of the reasons I'm excited to be on the call today is I think it's really important that we show the administration that there's no such thing as a cancer patient who's just a cancer patient. They all have comorbidities of one part or another. So we really share a lot of the same patients, if that makes any sense. And so I think it's really important that we speak with one voice. So the proposed rule is called the Modernizing Part D and Medicare Advantage to Lower Drug Prices and Reduce Out-of-Pocket Expenses rule. That's kind of a mouthful. So what I'm going to do with my presentation is talk about a little bit more in depth about the rule. So let's go to the next slide. So as Andrew mentioned, there are three key components to this rule, and I think that there's kind of something in here for everybody to really think about and comment on in terms of their space. So the first and foremost has to do with implementing prior authorization and step therapy for new starts and existing prescriptions. This is a continuation of some things that we've seen from the administration earlier this year, both in the Part B as in boy space, as well as in the Medicare Advantage space. This administration seems to believe that step therapy is clinically appropriate across all kinds of drugs. And again, whether you are a patient who is newly starting a therapy or you are on an existing prescription that works for you. To us, this is incredibly concerning in the oncology space because our patients don't have a lot of time to go through a step process. Cancer, as I think everyone knows, kills people, and time is definitely not a cancer patient's friend in that particular regard. So that's a very important part of the rule. The second part of the rule, which is a little bit kind of in the weeds, but stick with me, allows them to exclude drugs from the protected classes if a product is only a new formulation of existing single source drug or biologic product. This can be very concerning to patients. As you know, that might be something that was a multi-tablet regime that moves to a single tablet regime. There are many different advances that occur in terms of how drugs are formulated, mainly geared towards patient convenience. I haven't seen a lot of new formulations where patients have to take more pills than they did under the new state or the old state. So this would allow plans to exclude those products from the formulary. Obviously, from a patient perspective, we want to make sure that patient concerns are taken into account, and it's obviously easier in some cases for patients to take these new formulations. So we want to make sure that Medicare beneficiaries have access to those products. This rule actually would eliminate that. And then last but not least, this is going to allow drugs to be excluded from the formulary if their prices grow higher than the CPI, as Andrew mentioned. This is concerning because obviously drugs can increase in price for a variety of reasons, and could potentially knock certain drugs out of the protected classes. So let's go to the next slide for a second. So I wanted to go back to the step therapy piece because there are a couple pieces of this rule that I think are really important that we focus on. So as many of you might recall, earlier this year, not really that long ago, the administration put together a proposal to allow step therapy in Medicare Advantage for Part B, as in boy drugs. This rule actually codifies that. And what's important, I think, for you all to note is as part of implementing this policy, this is going to allow plans to force a patient to take a Part D drug before a Part B drug, or vice versa, a Part B drug before a Part D drug, or, you know, Part B to Part B, by going through step therapy. This is pretty unprecedented work. I will be clear with you that in the oncology space, the D drugs generally are cheaper than the B drugs, so we predict that we're going to see a lot of stepping from D to B. Some of the newest agents in oncology are infused therapies, which means they're in Part B. So we feel like there will be a lot of plans to implement this policy to reduce cost. And so I want to just call out that if this is something that you had commented on previously, that in fact this rule does codify that provision. And then let's go to the next slide for a second. So I guess on some level, it's not all bad news, and I have definitely heard from a lot of groups that they'd like to try and say something that's a little bit positive about some things. So there are actually two components of this rule that I think as patient advocates we need to take a heavy look at and offer some comments to. And the two pieces are the adoption of a real-time benefit tool and use of the explanation of benefits. So this rule would propose to require plan sponsors to implement a real-time benefit tool that would allow beneficiaries to have cost-sharing information at the point of prescribing. Basically, this would be done through electronic health record, and it would allow patients to better understand their cost-sharing and formulary alternatives. So I think the devil's going to be in the details in terms of how possible it is for this to actually be implemented, but we actually see this as a really positive step forward to provide patients better transparency around their cost sharing. So we actually feel like this is a positive step forward. The second requirement would be to require the inclusion of drug pricing information and lower cost therapeutic alternatives in the explanation of benefits that Part D plan members are sent. This, to me, I think is interesting, but I have absolutely no idea how it's going to be rolled out or actually implemented. So I think that from our perspective, I think we have a lot of questions about how will this work? Does this make any sense? But, you know, I do think that these are two nods towards trying to make sure that patients actually have information about the cost that they'll be paying, and we do see that as a significant step forward. So now that we've talked to you a little bit about the details of the plan, of the rule, I want to turn it over to, next slide, Catherine, who's going to talk to you a little bit about why this matters to you and what you can do. Catherine FINLEY is the Senior Advisor for the Partnership for Part D Access and a partner at Thorn Run Partners. Catherine?
Thank you, Pam, and thank everyone for joining. It's a pleasure to be here to be able to talk with you all about the work that we're doing through the partnership to preserve the protected class policy in the Medicare program. And a big piece of that is education. So if I could get the next slide. So Pam mentioned this just quickly. My background in this is really resonates back to the Hill. As Andrew knows, and even Pam, we were working together on this and contemplating how to preserve and protect the benefit for Medicaid beneficiaries in 2003 when I was with Senator Snowe, working on the development of the drug benefit. And then in 2008, I had the pleasure of being with Senator Smith and led the effort to codify the protected class policy in MIPA. And so in 2014, when we started to hear the concerns around the Obama administration and that they were going to make changes, we were able to reach into the patient community that had always been engaged and even expanded into new organizations whose patients were benefiting from this policy for so many years to stand up the partnership and really hit the ground running and making sure that we were able to impact the conversation that was going to take place. If you could turn to the next slide. This is just a quick reference of the range of organizations that are involved. There are many others, and through many of these groups, we reach out into even broader grassroots and other entities that are actively engaged over the years around protected classes. So we could go to the next slide. Just to give you a quick background, as I mentioned, the partnership was created in 2014. We have worked very hard to engage patient organizations from all 6 of the protected classes. And we continue to push a perspective that we are stronger together. And when we advocate with the administration on the Hill, when we look at data collection, our focus is truly around making sure that that policy leaders understand that the policy works the way it is because it works inherently for patients within all 6 of the classes. And as Pam mentioned, there's no patient, frankly, that has only one drug from one of the classes in the Medicare program. There's such a comorbidity between them. So we've worked very hard to make sure that that information is available and that staff and decision makers appreciate it. Would tell you historically in 2014, we were able to generate over 14 comments to HHS opposing their rule. And we generated a letter out of the House that had 50 bipartisan members from the Ways and Means and Energy and Commerce Committee and a letter from the Finance Committee that had every member on it. We've had staff briefings and hundreds of meetings up on the Hill. And then now as we enter into this new effort, looking at what is happening with regard to the Trump administration. We started it really at the beginning when Secretary Price came into office. We sent a letter urging him and informing him of the value of the protected classes. And so obviously that didn't have as much of an impact as we'd hoped. If we could turn to the next slide. Because we are looking at a new proposed rule that was issued on the 26th. And as Pam and Andrew both went through, it has a number of components that would be extremely detrimental to the patients in the Medicare program who use medications out of the 6 protected classes. So what we did as an initial engagement on this rule is that we released data that we had worked for a number of months with Avalier to develop. Avalier, for those who don't know, is a research organization here in DC, and they sit in a very unique space in that they're one of very few entities who have access to actual Part D claims data. So when we look at these numbers, these are not extrapolated from anything. They're not estimated. They are truly taken from Part D claims data. And so we started out really with a few questions that we wanted them to answer that we thought would help clarify what was going on in the protected classes. As you may know, many of the health plans have gone around town for a number of years saying that the protected classes ties their hands, that they must cover every drug, that they cannot use medication management, and that every patient is on the most expensive drug, whether they need it or not. And so we thought, well, let's look at that. Is that really the case? So we asked Avalier to look and see how many drugs are actually being covered by Part D plans. We asked them to look at how often utilization management is utilized. We asked them to look at tier placement of medications in protected classes, and we asked them to look at the utilization of coinsurance versus copay. What we found was that those policies are actively being used by Part D plans to drive patients into low-cost options. We found that only 67% of all drugs are being covered by Part D plans, which is significantly less than we would have expected. And of that, only 60% of branded drugs are being covered. And so when you look at it, clearly this idea that every drug is, that plans are forced to cover every drug is just simply not accurate. We also found out that while only 35% of covered medications in the protected classes are generic, 91% of prescriptions that were filled were actually for generic medications, going up as high in the antidepressant space to 97% of all scripts being filled were for a generic medication. We also found that about 40% of drugs in the protected class space are subject to some form of utilization management, whether that's prior authorization or step therapy. So again, when you think about it, large amount of effort being put forth by plans to use the tools that they have that already are allowed both through statute and regulation, and they are using those to aggressively drive patients into lower cost options. Next slide, please. So I'm pleased to report that our efforts around the report and getting out media coverage really worked. Our intent behind doing this was to make sure that the dialogue, which was starting to change in the bigger picture to cost. It was all about the cost of medicines, that we were keeping the protected class policy and that discussion focused on patients and on patients' access to medication and why those patients need access to these particular medications. And I can tell you that all the coverage that we've seen around the protected class policy has really called into question the administration's proposal. It has touted our stats from the data that we've developed with Avalier to really paint a bigger picture that balances this idea of lowering costs against the true cost to patients from restricting their access to medications. If I could get the next slide, please. So our next step moving forward is that we're in the process of launching an aggressive outreach to Capitol Hill. Folks, Andrew and some of Pam's colleagues, along with members from many other patient organizations, have been on the Hill with me this week, meeting with Republican and Democrat staff from the key committees of jurisdiction. We're in the process of reaching out and arranging a wide number of meetings on the Hill in January. And our effort is to make sure that we are educating and informing members, and the background or the basis of that education is really using the information from Avalier to demonstrate that the protected class policy right now is working. It's not only working for patients, but it has provided plans the tools that they need to effectively manage which drugs patients are using. And basically, our perspective has always been that for the vast majority of Medicare patients, they can take almost any medication that's appropriate for their condition. And that's what happens, and that's what our data shows. But there are a population of individuals for whom there's no way to predict who they are, but that we know once they're stable on their medications, they need to remain on that particular prescription. And that's what the protected classes is really all about. That once you're in a prescription and you're on a regimen and it's working for you, that you're able to keep that medication. And the other side of the coin would be if you have multiple chronic conditions and you have many medications you're taking, if you have a need for a new medication, the protected classes gives the physician the ability to find the right fit based on side effects, drug interactions to make it work for that patient. And so that's really the message we're bringing up to Capitol Hill. Beyond that, we will be working with our member organizations to further amplify our message. We're working on some webinars, just like the one I'm doing today. We're drafting disease-specific comment letters. We're doing broad protected class comment letters, working on talking points, and then working with the organizations that are part of the partnership to tap into their grassroots to lead their effort around sign-on letters. And all of that information is really in the process of being developed and fine-tuned, and we anticipate having much of it ready for when we hit the Hill in January. Next slide, please. So in conclusion, that's just a very, very quick overview of the partnership and what we're doing and what we have planned. But we look forward to being able to work with all of you to engage you, to be able to share our resources and to help you as you pursue activities with either the administration, Capitol Hill, news media organizations. We very much look forward to working with you. And for your reference, we have a very active and robust webpage. It's www.partdpartnership.org. I encourage folks to go to it. A lot of the resources, reports, and research that I've mentioned is already on there. Letters that we've done in the past, so you can see potential targets for outreach, members that have been active and engaged on this in the past. That is all on there and cataloged, so I encourage you to take a look, and hopefully those resources will be helpful to you. And so from here, I will turn it back over to my colleague, Andrew. I think he's going to share some work that NAMI's doing.
Andrew, I think maybe you're muted. While Andrew's unmuting, I just want to remind folks that if you have any questions, there is a Q&A box that you can ask questions, and we can start answering any questions that you might have.
This is Andrew Sperling. I apologize. I unmuted and it simply went blank for a while. But yes, please use the Q&A bar to ask any questions of the panelists. And while we're waiting for that, I might sort of kick things off with a brief question. Catherine, how long would we expect that it would take the administration to actually, once we get through the comment period at the end of January, do we have any estimate of a timeline of what it would take before the CMS published a final rule in order to have this new policy in effect for plan year 2020?
Well, you would expect that they'd have to move relatively quickly. The call letters typically come out in the beginning of the year. There's some flexibility, but it's usually around April. There's kind of a window, and I apologize, I can't remember, but it's about April, because plans then, that's kind of their opportunity to start to develop what their proposal will look like. Part D plans would only, submit related to pharmacy, but MA plans have to incorporate their proposals around the entire Medicare benefit package, of which the pharmacy changes would be a piece of. So I think our concern is that there would be a fairly quick turnaround, and that's why January and February in particular are so important. One of the things we've been talking with organizations that is, while members are home, if they have the ability to engage them, if they're local leaders of their organizations, their state chapters, trying to connect with members back in the districts, because they will be gone for the next week and a half, is really important. And then when we hit the ground running in January, it's extremely important that we get to as many members as we can, and that way they're well educated on the policies. And then beyond that, though the comment letter closes at the end of January, Congress can continue to weigh in, whether that's through, broad-based sign-on letters, whether that's calls, private conversations. So the effort doesn't really end in January, at the end of January. That's a real important part for the public effort to make sure we're getting comments in through the official process.
So if I'm looking in the right place, Katie, for questions.
Yep, Andrew, it looks like we don't have any questions at this time. So what I can tell folks is that we have recorded this webinar, and so we will put it on the ABC's website, and we will also be sharing some resources that Catherine mentioned and some others as well. We'll be sharing that with all of our ABC members on our website and through our communications process with you all.
And that will include, Katie, I'll send you shortly, we actually have some print ads that the national mental health organizations, including the APA, Mental Health America, SARTA, the Depression Bipolar Support Alliance, and NAMI are running print ads, and Politico and the Washington Post focused on how damaging this change in Medicare Part D would be for beneficiaries with mental illness.
Great, and that's great. We'll share that as well. And I should also note that we will be sharing all of your slides with the ABC membership as well. So I think, Andrew, you can, if you don't have anything further to add, you can go ahead and thank our guests.
Yeah, I certainly thank Pam. I thank Catherine. I thank you, Katie. I thank all the members of the American Brain Coalition. NAMI's a proud member of the American Brain Coalition, and I'm particularly pleased to be able to serve on the ABC board. So thank you all for being here, and please engage with us on this. And your organization, we'd strongly urge you to be submitting comments to CMS ahead of the January 25th deadline. Thank you very much.
Thank you very much. Thank you, Andrew, and all of our speakers. Thanks. Happy holidays.